Okay. Welcome to our symposium, and thank you for coming. There's a couple of points that I'd like to go over before we get into the real content of this program. These are the instructions for in-person learners. QR code you've already heard about, and I think you're all set to go. So this is going to be a real treat. I'm going to be presenting with Dr. Corren Castro on the topic of really mucus plugging and airways hyperresponsiveness in patients with asthma, how we identify it and how we can treat it better. Dr. Castro to my right, as many of you know, is really a world-renowned authority on asthma in general, has been involved in some of the sentinel trials over the past decade, along with a very active research interest in this particular area of mucus plugging. So I think we're going to hear some really interesting data from Dr. Castro. And lest I not forget, I'd like to thank the folks from AstraZeneca for making this kind of a program possible for all of you attending. As a reminder, look for additional follow-up that will be rolling out in terms of polling after the program. And please submit your questions to us as we work through this program so we can answer them for you. And this is a reminder where you can get the slides if you like them, and I think they are quite good actually. You can get access to them online. So we have a few goals that we'd like to try to achieve tonight. The first being to discuss the role of mucus plugging and airway hyperresponsiveness in patients with asthma, and to really correlate that with declines in lung function, asthma symptom severity, and potentially implications for treatment, particularly with some of the recent developments that we've witnessed. We're hoping to impart information about high-resolution CT scanning in patients with asthma, and maybe give you an impetus as to when you would do this and why you would do it in order to potentially deliver better quality care. And then finally, we're going to hope to apply some recent insights into this area of mucus plugging and airway hyperresponsiveness, and provide you with some really evidence-based approaches to how these two specific issues may be dealt with therapeutically. So we're going to start with an audience assessment. Starting off with, let us know what kind of practitioner you are, or whether you're in the pharmacy field. Go ahead and answer that, and we'll have a couple more polling questions just in a moment. Okay. So we're going to start off. The second question is, please select the category that best describes you, and these results will not be shown. So we're going to go right into the case study. Okay. And we're going to, as part of the audience assessment, how many patients with moderate to severe asthma do you encounter each week with these numbers shown? So if you can let us know that. Which of the following practice settings is most applicable to you, if you can let us know? So now we get into some clinical issues, and this is the first polling question. How often do you currently use chest CT scans to assess your patients with severe asthma for the presence of mucus plugs? And we have never, rarely, sometimes, frequently, always, or you're not sure. Here's another polling question. Which of the following statements about mucus plugging is true in your opinion? Number one, mucus plugs usually occur in the absence of bronchiectasis. Secondly, mucus plugs are associated with neutrophilic inflammation. Third, symptoms such as cough and sputum production are directly correlated with mucus plugs. Number four, although mucus plugs have a detrimental effect on lung function, they typically will resolve within a year, or you're not sure. Question three, which of the following statements about airways hyperresponsiveness is or are true? Most patients with severe asthma do not experience airways hyperresponsiveness. Second, the level of intensity of airways hyperresponsiveness tends to remain stable among patients with asthma. Number three, the presence of airway hyperresponsiveness is associated with increased decline in lung function, even in those with asymptomatic airways hyperresponsiveness. Four, increase in airway hyperresponsiveness is not associated with underlying severity of asthma, or you're not sure. Number four, you are managing a 45-year-old patient with severe uncontrolled asthma on inhaled corticosteroids, long-acting beta agonists, and leukotriene receptor antagonists, who has mucus plugs in the lower lobes of 4 bilateral lung segments. Based on published data surrounding its role in reducing mucus plugging, what would you do next? Number one, recommend treatment with omalizumab. Number two, initiate budesonide therapy. 3, prescribe formoterol therapy. 4, recommend treatment with tezepelumab, or you're not sure. And our last polling question. How would you rate your current level of understanding of the potential role of biologic agents in the management of patients with severe asthma who have mucus plugs? Number one, I have no understanding of the potential role of biologic agents in the management of patients with severe asthma who have mucus plugs. Number two, limited. Number three, average. Number four, above average. Number five, excellent, or you're not sure. Now the music stops and we can start our program. So we'll start with a case study. Okay. Our patient is a 42-year-old with increasing asthma over the past 2 years. He's unable to control asthma with his current regimen, which consists of an inhaled corticosteroids and long-acting beta agonists. Or he's been unsuccessful as well with tiotropium, bromide, as well as montelukast. Over the past year, he's had 4 exacerbations, a large number that required oral corticosteroids. And of note, most of these episodes were not initiated by an obvious viral infection. Other associated history consists of chronic nasal congestion and some thick postnasal drip, which varies in color from clear to occasionally yellow. And he does have occasional heartburn that he treats with Tums. His current medicines include fluticasone, vilanterol at the higher dose, 200/25, and he lives very close to the beach and works out of his home. He has no pets, and he did smoke briefly, younger part of his life, but currently doesn't smoke and occasionally smokes marijuana. So his examination demonstrates some things that we would expect to find. His blood pressure is normal, there's a normal pulse. Oxygen saturation is completely normal. His head and neck exam shows a little bit of nasal congestion with some clear discharge, but otherwise no polyps, no pus. And his lungs do demonstrate some wheezing with forced expiration. His blood count shows a normal hemoglobin and hematocrit. He does have 5% eosinophils, but more importantly, his absolute eosinophil count is 425. His total IgE is 470. Allergy skin tests were positive to dust mites, to some very critical molds, including Aspergillus and Alternaria alternata. And an Aspergillus IgG was ordered, but not detected. If we look at his pulmonary function, FVC is 72% predicted with quite a severely depressed FEV1 of 58%. His ratio is clearly obstructed at 0.65, and his FEF 2575 is at 37% predicted. He has a complete lung function, which shows that his thoracic gas volume is significantly elevated, indicating air trapping, and his DLCO over alveolar ventilation is normal, with an exhaled nitric oxide of 48 parts per billion. Based on his history, the severity of his disease, a chest x-ray is obtained. There's some definite parabronchial thickening, and at the bases of both lungs, a little bit of atelectasis. And then finally, a CT of the sinus was ordered because of the provocative role that might play in his chronic symptoms. And there's some periosteal thickening, some mucosal thickening, without any evidence of gross polyposis or air fluid levels. And that is his high-resolution CT scan. Mario, do you want to take a glance at that and tell me what your thoughts are on that scan?
Yeah, so I think the most remarkable findings is in that right mid-lung area where you see those opacities, and those are basically opacification of the bronchopulmonary segment with a mucus plug in that location. I think there's some other areas where you can see some distal kind of bronchial lectasis, like in the left mid-lung area, but I think the remarkable findings are the mucus plugs that you see there, and I'm sure there's probably more.
In this cut, do you see any bronchiectasis?
Not, if you could probably remove the mucus plug, you might see it.
Okay,
but
good point.
I can't point it out just based on this view.
Okay, so I think that really sets the stage for the next part of the symposium. Dr. Castro is now going to talk about mucus plugging, so I'm going to turn the program over to you.
Great, thank you. Thank you, Jonathan, and thank you all for attending tonight, and hopefully we'll come back with some new information as we talk about the role of mucus plugging. So first, let's just start out with basics. What are mucus plugs? As noted here, they're really just a mixture of water and mucin proteins, and it does have a normal function, which is to help with mucociliary clearance. However, what happens in asthma is that there's an inversion of this ratio of the 5AC, MUC5AC to MUC5B, and so there's a lot more concentration of MUC5AC, and that makes the mucus plug sticky, and it creates problems for our patients, as you can imagine. It starts to cause occlusion, and that leads to, distal to that, some atelectasis, air trapping, and if it's severe enough, certainly can cause desaturation, but not typically in our asthma patients. So when we think about how we evaluate mucus plugs, typically we're just asking the radiologist what they think, but there's a lot more science behind this that we could actually apply. So as demonstrated in this cross-sectional area here, you want to basically find the mucus plugs that occludes the entire lumen. So we don't count those that have kind of partial occlusion from mucus. It has to have total occlusion. In a study we did of 146 individuals with asthma and a smaller group of comparison of healthy controls, we then quantified this by 5 chest radiologists going through each individual segment and give us a score from of 0 or 1 for each segment. So they would go through each one of these bronchopulmonary segments. So you have 10 on the right, 10 on the left. And so you can generate a score anywhere from 0 to 20 in these patients. We'll go through some of the findings here, but it's listed here. Over half the patients had at least one mucus plug. And this is the way we classify the degree of plugging. So if you had no plugging, well, you were 0. If you had high mucus plugging, that would be 4 or more segments. that had a mucus plug in them, and then in between is in that intermediate group or that low mucus plug phenotype. So as we'll talk about this, I'm going to start referring to this as a mucus plug phenotype, because I think this is something that, we're used to talking about allergic phenotype and the eosinophilic phenotype. But this is actually a new phenotype which has, I think, its own distinct drivers behind it and can be used for targeted therapy. Now, when we look at the distribution of those mucus plugs, as demonstrated in this color coding here, the lowest number of mucus plugs tend to be in these areas here in green. The intermediate kind of number of mucus plugs or proportion of mucus plugs is in the amber color here, and the highest regions being in kind of red down here in this brick red. So indicating is that when we go looking for the mucus plugs, the majority of them are going to be in those lower lung zones in these patients. Now, in the SARP Severe Asthma Research Program, this was a study published by Eleanor Dunnigan. We published this in JCI. We described, again, these 146 subjects into those 3 different categories. I'm just going to focus on the high mucus plug phenotype and point out some key features. Tend to be a little bit older, which goes along with the severity of their disease. You can see 90% of them had severe asthma in comparison to the other groups. And you can see their asthma controls a little bit worse. Their ACT scores are lower than the other patients. But really one of the striking things is the degree of airflow obstruction that they have, with an FEV1% predicted of 56%. You can also look at their T2 biomarkers there and notice that they're elevated. Their blood eosinophil level on average 459, their FeNO 28 parts per billion, and about 27% of them had evidence of bronchiectasis, and we're going to get more into that bronchiectasis subsequently. What are the consequences of that plug in that segment? Well, distal to that, you can imagine you can have air trapping, but it's also going to contribute to proximal airflow obstruction. And we'll talk more about the clinical consequences of the data that we'll show from SARP, as well as another study subsequent to ours. And these patients have more frequent exacerbations and increased risk of infections. Now, one key thing is that history doesn't help you. Unfortunately, when we looked at our SARP population and asked patients about the presence of cough and sputum production using the chronic bronchitis definition here, you can see that the patients that had the highest mucus scores really had no positive response to that question. So there's not a correlation between what patients are telling us in terms of mucus production and the presence of these mucus plugs. And when we think about how can we quantify this, again, the way we did it in SARP was we did it through the use of chest CT scans and going systematically through each one of those bronchopulmonary segments. Certainly, I think it's a less invasive way than going there bronchoscopically and trying to remove the mucus plugs, but certainly this is a way to not interfere and still get some valuable additional data on your patients. When we think about that first question, I want you now to answer this question. Based on what you just learned, how often would you use chest CT scans to assess your patients with severe asthma for the presence of mucus plugs? All right, and as we go through here, if you have questions about any of the material that we're presenting, please go ahead and put that through your polling question from that QR code. When we look at the distribution of those mucus plugs, one of the things we did then, we asked the chest radiologist to simultaneously score whether or not there was bronchiectasis. And you can see the proportion of subjects, the majority of these subjects, had no evidence of bronchiectasis, with a distribution across the various lobes. You can see here in terms of the right side or the left side. But the majority of these patients that have mucus plugs in these locations do not have bronchiectasis present. So you can see here there's a disproportional effect either by looking at the presence of mucus plugging here. You can see only a small proportion of those segments have bronchiectasis. So bronchiectasis is not a necessary feature for the presence of mucus plugging. As we talked about, those patients with a high mucus plug score tend to have the worst lung function. You can see here on average around the mid-50s in terms of FEV1% predicted. The intermediate group, that low mucus plug phenotype, is kind of intermediate between those two, and pretty consistent results for the FEC and FE1 FEC. And you can see here, if you look at an FE1 less than 60% are predicted, the greatest proportion of that high mucus plug group is in that group. Now, the second thing we learned was that these mucus plug phenotype is associated with T2 inflammation. So when you look at the mucus score here, the distribution, you can see simultaneously when we looked at the sputum eosinophils or airway eosinophils, pretty good correlation between the two. And when we use the Th2 mean or the T2 mean to classify the subjects, whether or not they were T2 high or T2 low, you can see here the results for IL-13 and IL-5. And you can see that the high mucus plug group has the highest levels of IL-13 and highest levels of IL-5, suggesting again that there was there was a correlation between the presence of mucus plugs and T2 inflammation. The other thing that you'll note here is this, before steroids, we gave patients that participated in this study IM triamcinolone, and then we repeated their lung function subsequently, 3 weeks subsequent to that. But there was really no impact of the before or after the steroid on the T2 inflammation associated in these patients. When we look into this further in terms of the eosinophils, you can see here that one of the products that we were able to measure in the sputum is peroxidase. Again, has a correlation between the presence of sputum eosinophils, not too surprising. But what is remarkable is that these patients with a high mucus plug phenotype has the greatest levels of EPO in the sputum, suggesting again a direct relationship between the mucus plugs and the presence of eosinophil products in the airway. That a recent study led by Monica Tang has now added some additional information about that initial study. To build on that initial study, is we repeated scans in 164 patients 3 years later. We were very interested to see what happens to these mucus plugs over time. Now, as you can see in this patient here, the presence of this mucus plug at baseline, and then subsequent 3 years later, it's still present there. So at least suggesting that there is a persistence of mucus plugs. When we look at what happens to the mucus plugs over time, this again correlated with a change in eosinophilia in the blood, as well as in the airway. Not huge correlations, but certainly a trend towards there being a correlation of how does the mucus plug change over time, and then what happens to the markers of eosinophils. Now, this has also been replicated in other studies. This is a study from Sarah Svensson's group in Canada. The first panel here is a hyperpolarized gas MRI panel with, in this particular study, using helium. So it's looking at ventilation in the lung, and is that gas, because it's hyperpolarized, should look white throughout the lung. You can see that there's a large area here where there's very little ventilation going into that. And it corresponds exactly with the presence of mucus plug. So in this smaller study of 27 adults, there were mucus plugs in about 2/3 of patients. Recall in the SARP data, it was a little bit over 50%. And this presence of mucus plugs was associated in their study also with sputum eosinophils, IL-4 levels in the sputum, as well as exhaled nitric oxide. So again, a separate study showing that there's a tie with mucus plugs and T2 inflammation. A subsequent study by Rory Chan, this is Brian Lipwith's group in Dundee, was a real-world study of 126 patients that underwent CT scans. This was a retrospective look at these patients that went through kind of systematic characterization of their disease. And they used the same SARP kind of algorithm in terms of looking at the presence of mucus plugs and that using that 0 to 20 score. And what was interesting from Rory Chan's study was that there is, again, this association with airflow obstruction, 67% higher likelihood of obstruction, higher likelihood of exacerbations, and again, higher blood eosinophil levels, but also importantly, they noted that there was association with Ig levels and also specifically with positive specific IgE to Aspergillus fumigatus. And in fact, a 9-fold increased risk of them having mucus plugs with the positive titer. And these were the various odds ratios that were for each one of these clinical characteristics: airflow obstruction, exacerbations, peripheral blood eosinophils, and Ig level. Well, Manakatane also demonstrated that these mucus plugs persist in the SARP study. This is a Sankey plot showing the proportion at baseline and then the proportion 3 years later. And of course, the change here is indicating somebody that went from having a plug at baseline to not having a plug 3 years later. But you can see some of these that didn't have plugs also then to develop. So about the same proportion out there. And the majority of these, 3 out of 4 subjects that have a plug, it stays in the same subsegment. So it doesn't really move around over time. It stays in that same subsegment. And if you look at different parts of the lung, you can see the blue here being persistence of the plug and purple being intermittent plug, so that the plug was present at baseline or year 3, but not necessarily at both time points. So you can see that the distribution is pretty good. There are pretty even across the lung. There is a slight proportional increase in the lower lobes. When we look at, again, the change in that mucus score over time, direct inverse correlation with lung function. Importantly, as you get worsening mucus plugs over time, you're losing lung function. So a direct correlation between these two. And then this is a measure of basically air trapping that's occurring in these patients. So you're going to get greater air trapping with more mucus plugging. So a follow-up question here: which of the following statements about mucus plugging is true? Let's see if you captured some tidbits of information as we shared here. Number 1, mucus plugs occur in the absence of bronchiectasis. We're going to pick the one that's true now. Mucus plugs are associated with neutrophilic inflammation. Symptoms such as cough, sputum production are directly correlated with mucus plugs. And 4, mucus plugs have a detrimental effect on lung function. They typically resolve within a year. Or 5, I'm not sure. Go ahead. All right, so hopefully most of you picked that first one because it does occur in the absence of that bronchiectasis. We now like to move on to kind of talking about airway hyperresponsiveness. As Dr. Corren mentioned, this is an area of focus with a number of the biologics that he'll be talking about, and we're going to set the stage for what he's going to show on the second part of this talk. We know in terms of our patients, one of the key features of their disease is the presence of airway hyperresponsiveness. It's part of the definition of asthma, and that's demonstrated here in terms of having a hypersensitivity in our subjects with asthma to methacholine in terms of percent fall and lung function in comparison to healthy controls. The other thing is that you can induce bronchoprovocation in somebody that's healthy if you give a high enough dose. We know this is a key characteristic feature of asthma, but there is some considerable variability, which we'll talk about. And this variability may reflect the underlying disease process, may reflect some of the variability in the testing for airway hyperresponsiveness, but certainly is a key feature. We also believe that it's related to the underlying remodeling that's present in the airways. That remodeling process also can cause patients to be more hyperreactive. So there's a correlation between that remodeling and the presence of airway hyperresponsiveness as well. And then importantly, we know that if you have airway hyperreactivity, you're going to have greater decline in lung function, even if you're asymptomatic. You can see here in children, if you have this, and it persists in children, that these patients do have greater likelihood of developing asthma and also greater likelihood of decline in lung function. And we demonstrated this in a study we did a few years ago, post-RSV bronchiolitis in infants. When we followed them to 6-7 years of age, we started measuring airway hyperresponsiveness with methacholine, and we were very surprised that over half of them had airway hyperresponsiveness, and a significant proportion of those went on to develop asthma. So it does appear to be kind of one of these risk factors for subsequent development of the disease process. When we look at airway hyperresponsiveness, the key features here, and we'll talk about some studies that substantiate this, it has a specificity around 90%, but relatively lower sensitivity, and it really depends on the underlying population that you're studying. When we talk about the different forms of bronchial hyperresponsiveness testing or hyperreactivity testing, you can do a direct test either with methacholine or histamine, which is going to reflect the twitchiness of that airway smooth muscle, or you can do an indirect test such as mannitol, which is going to increase osmolarity, causing a release of mediators that lead to that bronchoconstriction. And there's some other ones that have been used for bronchoprovocation testing that's listed here. Now, this interesting study by Aaron and colleagues wanted to bring out because it really shows some key features of airway hyperresponsiveness that lead to our understanding of how we make the diagnosis of asthma. In this large study of 700 adults from the community, they went through rigorous testing. So they did bronchodilator testing first. If that was positive, great, you have a diagnosis of asthma confirmed. If it's negative, we're going to do a methacholine challenge. And if it was negative to the methacholine, then they would cut their medications by 50%, repeat the methacholine 4 weeks later. If it was still negative, then they would do it again 4 weeks later off of all medications. And what they found was about 33% of the patients had multiple negative methacholines off of their medications and did not have the diagnosis of asthma. So the misdiagnosis of asthma was noted in this study. And you can see here 30% continued to exhibit no symptoms 1 year later. There are limitations to this testing. This was a study by Cajal Sumino as part of our AsthmaNet cohort, AsthmaNet study. And in this study, we tested, actually it was part of the ALA, ACRC. We tested in a population of patients diagnosed with asthma by asthma experts, and we found that the sensitivity of methacholine testing was about 77% and specificity was 96%. And interesting, in this study, the sensitivity was worse in Caucasians than it was in blacks. And also you can see there for non-atopic patients. Polling question: which of the following statements about airway hyperresponsiveness is true? Most patients do not experience airway hyperresponsiveness with severe asthma. Number 2, level intensity remains stable. 3, presence of airway hyperresponsiveness associated with increased decline, even those with asymptomatic airway hyperresponsiveness. 4, increase in airway hyperresponses, not associated with underlying severity, or 5, I'm not sure. All right. Hopefully, most of you took that take home. Number 3 was correct. That's associated with that greater decline in lung function. So just to summarize kind of my part, I'm going to turn it over to my colleague here. We've demonstrated that this mucus plug is a new phenotype that you can use high-res CT to identify. We know that this is associated with T2 inflammation. We know that it's associated with marked reduction in lung function. And we also know that if you measure airway hyperresponsiveness, that's again associated with this more rapid decline in lung function. And also that this is an important diagnostic test in patients because of that underlying misdiagnosis that occurs with asthma. So these are key features that I'm going to then turn it over to Jonathan to take us into the next part.
Thank you, Mario. So in this last section, pardon me, we're going to be talking about the clinical implications of mucus plugging and airway hyperresponsiveness in terms of choosing biologic treatments for patients who do suffer from severe asthma. So what do we have right now at our disposal for treating patients where we pick up mucus plugging by CT scan? We can have them nebulize hypertonic saline. That may or may not work, may be irritating. There are mucolytics that we have, but they're really the currently available options may not really have all that much efficacy, and that's what we've all learned from clinical practice. And there are some novel compounds that are being evaluated which might potentially be more efficacious. And then in patients who have type 2 low asthma, the use of microlides like azithromycin has been shown to have some effect on mucus production and mucus plugging. And typically it's used to treat exacerbations in patients who have a low type 2 phenotype. So what are the biologic targets where these particular cytokines may be playing a role in the development of mucus plugging? So we start with the most upstream part of the airway, the epithelium, and we know that alarmins like thymic stromal lymphopoietin or TSLP are released, which then have the capacity to upregulate IL-4, IL-13, and IL-5. So TSLP we know is now antagonizable using tezepelumab, and we know that the currently approved drug for blocking the IL-4 and 13 receptors is dupilumab. But we know that IL-4 and 13 certainly are part of the picture. IL-5, which leads to eosinophilia, first in the blood and then later in the airway, can be blocked using IL-5 antagonists like mepolizumab and benralizumab. And then finally, omalizumab. The role of IgE in engendering allergic asthma certainly does lead to mucus plugging, and there has been some attempt to define how much of an effect a blocker of that can actually have on preventing or reducing mucus plugging. So we're going to start with some data on benralizumab and the effect it has on mucus plugs in severe asthma. This is a sort of modestly sized sample of patients who had severe asthma, close to 40. In an open label fashion, a number of different parameters were examined after they had been treated for a month, then several months, and a year, and then all the way out to 2.5 years with chronic dosing every 2 months. And what we can see is, starting in the upper left, the effect on FEV1, certainly over time, seems to get better. Asthma Control Questionnaire number 6 seems to show a definite diminution that continues over time. FeNO, as you can see, comparing the 2.5-year time point with baseline, there was a statistically significant difference. Ventilation defects defined by magnetic resonance imaging shows a definite reduction in those ventilation defects with the use of an IL-5 blocker. Then we have the mucus score on the left, lower, and we have total airway count, definable as the loss of mucus plugging, and we can see that there is both a reduction in the score and an increase in the definable count. The lumen area goes up, as does wall thickness, and all of these things went up statistically with chronic use of a drug that targets the IL-5 receptor and eliminates eosinophils from both the circulation and to some extent, as we're going to see, from lung tissue. And this gives you an idea, looking at a single patient, what we can accomplish in a patient with the appropriately chosen drug in terms of eliminating the mucus from the lumen of an airway. And this is after 2.5 years of treatment. So if we try to define this a little bit better, and here we're doing a small open label study with some very, very highly reproducible endpoints. And we're looking at the effect of benralizumab on mucus plugging in another trial. And on the left, we're looking at mucus plug count, we're looking at sputum eosinophils in the middle, and we're looking at eosinophilic cationic protein in the right. And what we see are some dramatic results, keeping in mind that it is an open label study without a placebo control. But certainly the number of eosinophils or the number of airways that are plugged drops dramatically. Similarly, for sputum eosinophils, there is a reduction. And then finally, for the amount of ECP that was stainable in the airway. So we're seeing that by blocking the entry of eosinophils into the serum or into the blood, that we can achieve some really important findings in patients who have severe asthma. Less work has been done by antagonizing IL-4 and 13, by blocking their receptor. In this case, we're looking at dupilumab in a single case report, but I think it's worth showing this because it really gives you an idea on the left of the degree of mucus plugging in somebody who has severe asthma, as Dr. Castro, I think, has defined so nicely for us. And then we can see visibly to the naked eye, without having to do any kind of a computer analysis, the marked improvement in plugging after treatment for a number of months. So newest on the scene is a drug that blocks TSLP by binding to TSLP as its ligand. And in a cascade study, there have been some attempts to really define what kind of improvements, if any changes, do occur with tezepelumab. In this case, we're looking at placebo-controlled data, and this is a study of patients over a period. It was a part of a phase 2 randomized double-blind study with tezepelumab. And we can see that on the left, tezepelumab universally dropped the mucus plugging score, and we compare that with placebo, and again, pretty reproducible in the placebo group because these plugs do stay present for a number of months or longer. And the reduction in mucus score was correlated with improvements in FEV1. So we know not only are we having anatomic changes with this chronic mucus infiltration of these airways, but it has a functional consequence to the patient, which correlates in of itself with future exacerbations and quality of life. And if we look again at something visual that we can really lay our eyes on, very similar to what we saw with benralizumab, we can see in this patient a marked improvement in that one particular plug, which is very easily witnessed here, and we can see clearance of that after treatment. So if we try to define this in a slightly more quantitative way, and at the top we're looking at mucus scores, and we're defining it as either no plug or a plug is present. And what we can see on the left, going to the very top set of graphics here, that there was a plug present at the start of the study and no plug by the end of the study, and we're looking probably at about a 60% reduction in plugs. So this is something that I think was really dramatic. If we look down right below it, we're looking at the change in mucus plugging, again, defining a somewhat different way with active drug. We're looking at high, low, and zero plugs. And if we simply look at the zero and low together, which constitutes about 70% of the group at baseline, that increases to 100% of the group, with a large number of the patients having zero plugging, probably the vast majority, and a smaller group having a lower level of plugging. And if we now compare this with the right-handed set of graphs, what we can see is that plugging, first of all, is very consistent. The data before and after the placebo period of treatment is almost identical. So we have a very reproducible endpoint. We have a very powerful effect with this particular drug. By blocking TSLP, we see an improvement in plugging with many more patients having no plugs or just a low level of plugging. So going along with the same study and trying to derive more data from it, what's interesting about the data I'm about to show you is that the patients were divided into patients who had no plugging or plugging at the onset of the study. So that allows us, for instance, to look here, patient with plug, patient with no plug, and we're looking at pre-bronchodilator FEV1. So we can see the change in lung function as a predicate of patients who either have no plugging or plugging. Those that had plugging, treated with tezepelumab by virtue of elimination of those plugs, have a statistically significantly greater improvement in FEV1. So a lot of this change in FEV1 that we're seeing in these patients is really based upon the clearance of plugging, which is maybe quite diffuse in some patients. And if we continue along the same line, we can see this is FEV1 presented in a different matter. This is FEF 2575. Again, the greater improvement seen in patients who have plugging present at baseline. And here, we're looking at a couple of other things, ACQ6, and then finally, the change in FEC, where we didn't really see a lot of change, whether there was plugging or not, in comparison with the blue placebo groups in this study. So certainly many of the parameters that we look at in spirometry were significantly improved, particularly in those patients who had mucus plugging. So a follow-up question for you all. You're managing a 45-year-old patient with severe uncontrolled asthma on inhaled corticosteroids and long-acting beta agonists, leukotriene receptor antagonists, who has mucus plugs in the lower lobes of 4 bilateral lung segments. Based on published data supporting its role in reducing mucus plugging, what would you do next? Number 1, treatment with omalizumab. 2nd, initiate budesonide treatment. 3rd, prescribe formoterol. And 4th, recommend treatment with tezepelumab, or you're not sure. So take a moment to consider that. And our last polling question. To remind you of what we saw earlier in the presentation and how you would answer this now, how would you now rate your current level of understanding of the potential role of biologic agents in the management of patients with severe asthma who have mucus plugs? 1, I have no understanding of this relationship. 2, it's limited. 3, average. 4, above average. 5, excellent. Or 6, you're still not sure. And we appreciate you filling out all these polling questions because it's important information to gauge how this approach to education really impacts on your level of knowledge. So Dr. Castro really set the stage for airways hyperresponsiveness. What is it? How do we measure it? Does it make a difference? And we're going to look at some of the trials that have been done. And in summary, we can look down and see, starting with Dr. Noga in 2003, you can see that there were 3 studies done with omalizumab. The challenge agent varied between the studies from acetylcholine to methacholine to cyclic or to AMP. 2 studies looked at mepolizumab. Both used direct vasoconstrictors, methacholine and histamine. And then very much more recently, 2 studies with tezepelumab where the agonist of choice was mannitol, an indirect acting agent. The reason mannitol was picked in this study and perhaps not the others, because there was a large level of interest whether blocking of TSLP might have an effect on mast cells. And as you remember, mannitol, which is basically a hyperosmolar agent, by exposing the airway to mannitol, you get a change in the osmolarity around these cells, and these cells then rupture, releasing their interior contents like histamine and prostaglandins and leukotrienes. And you can see the kind of changes that were present in these studies. We're going to look at this, I think, in a visually more appealing way in a moment. This shows some of the key studies that were done. To the left actually shows a worsening of responsiveness, to the right an improvement. An improvement by virtue of the fact that it would take more doubling doses of the agonist in order to induce the same level of change in pulmonary function. In the case of methacholine, typically it's 20%. But in the case of the 2 studies at the bottom with tezepelumab, typically it's 10 to 15%, because it's a little harder to get those mast cells to degranulate in response to mannitol. So we can see that certainly many of the agents that we've used do affect various aspects of nonspecific airways hyperresponsiveness, including the most recent studies with tezepelumab. So we can kind of take a circle back, take a step backward, and ask ourselves, TSLP, what does it do? Why is it important? As I've mentioned, it's an upstream cytokine. It's an alarmin, along with IL-33 and IL-25. It has a powerful effect on regulating type 2 immunity, which is particularly relevant to patients who have inflammatory airways disease. Has an effect on the generation of eosinophils. It has an effect on the generation of exhaled nitric oxide. And very importantly, as we're going to see, it in fact does affect airways hyperresponsiveness and potentially via an effect on mast cells. And there's been some data looking at the change in phenotype of mast cells in the airway after exposure to tezepelumab, and this may have some importance with regard to why the drug seems to be effective in abrogating nonspecific airway hyperactivity. So we'll start with some data coming out of the upstream study, a study that used a 12-week point in order to measure some of the most important outcomes in the study. Again, this study also used mannitol as the agonist for inducing bronchospasm. And what we see is placebo, where there was, just by virtue of being in the study and a lot of good supportive care, their reactivity to mannitol got a little bit better. There was a 1 doubling dose improvement. But if we compare that with tezepelumab, although it didn't reach statistical significance, at the 12-week time point it was very close with a p-value of 0.06, but we can see that there was almost a twofold doubling shift of the amount of mannitol required to induce bronchospasm. And even moreover, patients who underwent this trial, those who completely lost mannitol hyperresponsiveness, was statistically higher and better in the patients receiving the active treatment of tezepelumab. Now, we're all interested in inflammation. We've been talking about eosinophils since Jean Bousquet's paper in 1991, where we realized they played a role in the pathogenesis of asthma. And as part of the upstream study, they actually did do bronchoscopies. They got bronchoalveolar lavage fluid, they got sputum, they got tissue, and they got blood, all for the examination of eosinophils along with some other cells. What we're looking at here is the eosinophilic data. And we can see placebo, shown in blue, is certainly at a much higher level than the patients who received tezepelumab. And if we look at the box in red next door to all of this raw data, we can see that in the BAL fluid, there was a 75% reduction in eosinophils compared with only 7% for those on placebo. Sputum from 69%, a reduction compared with 26% on placebo. And then finally in the blood, not as much of an improvement, minus 39% versus 19%. I always find it interesting that with tezepelumab and blocking TSLP, we see more dramatic changes in the lung tissue than we do in the blood. And you can think about that for a second and ponder why that might be. But by actually having an effect on the cytokine IL-5 that's responsible for getting eosinophils out of the bone marrow and matured and allowing them to survive on their way to the lung, but also by abrogating the effects of IL-13, 2 cytokines simultaneously, which is responsible for upregulating adhesion molecules like VCAM1, as well as the release of chemokines like eotaxin 3. If you can hit IL-5 significantly and hit IL-13 significantly, you not only prevent these things from getting into the blood, but even more so, you prevent them from getting into lung tissue. And that may be why we're seeing this really very robust effect in the BAL and in the sputum. In terms of exhaled nitric oxide, again, we can see that there was an effect, in this case not statistically significant, and that may be by virtue of the sample size, although with a 48% reduction, I think it was really quite robust. Some of the other results that you might find interesting that are in the paper, the relative changes in neutrophils and lymphocytes, in total IgE and basophils, really didn't differ between the groups. And part of this is by virtue of the length of treatment. It was only several weeks, and by sample size. When we look at some of the large phase 2b and phase 3 studies, we do see really robust changes in things like blood eosinophils, FeNO, and IgE. ACQ6 decreased by 1 point in the tezepelumab versus 0.5 in the patients with placebo, a trend but not statistically significant. And adverse events were very similar between the two groups. So what we conclude is, when you block an upstream cytokine like TSLP for really a very short period of time, only 12 weeks, using tezepelumab, we didn't see a significant reduction in airways hyperresponsive to mannitol. But as I mentioned, the proportion of patients who completely lost their airway hyperresponsiveness to mannitol was statistically higher in those patients getting active treatment. And I think, moreover, when we try to define, are we able to eliminate eosinophils, either from blood or tissue, certainly the changes that we saw with tezepelumab were very significant. And I think this relates back to what Dr. Castro was talking about, that you really need eosinophils, and you need mucus, and you need some oxidation for cross-linking to form these plugs. Other biologic agents and airways hyperresponsiveness, and here we're looking again back to benralizumab, the drug that attaches itself to the IL-5 receptor and causes apoptosis of eosinophils. And what was found in the study was that there were some significant inhibition of AHR to histamine that was seen with this particular drug. And I think in conclusion, you really can't say how these drugs compare because we have no head-to-head comparisons. I think we can speculate, we can look at the data that exists, but we're really touching the tip of the iceberg at this point in our exploration of this particular phenomenon. If we look at eosinophil depletion with benralizumab, it's associated with attenuated mannitol, airways hyperresponsiveness, and severe asthma. And when we actually look at this data, as you can see, mannitol challenge was done sequentially over a period of time, and what actually was seen was a loss of airways hyperresponsiveness, an improvement in asthma control questionnaire scores, and a reduction in peripheral blood eosinophils. This gives us some of the mannitol data from that study, and what we're looking at, we'll focus on the left, the PD15, which is shown in the upper graph, and we can see that it goes up sequentially over a period of just, I think it was 24 weeks. And then in concert with that, if we look at asthma control questionnaire and the AQLQ, we see that the ACQ goes down below the identity line and AQLQ goes up. I think testimonials to not only are we getting objective changes in hyperresponsiveness, but to some extent this is going along with changes in some of the subjective parameters that we follow in severe asthma. Now, as you can tell from this particular table, there's a lot of interest in this. I think we're really getting to the point in asthma as well as in COPD about the importance of mucus and the importance of plugging and how this has a long-term effect on the future of these patients, where they're going to continue to lose lung function and maybe ultimately develop bronchiectasis, which is much harder to manage. And you can see with benralizumab, dupilumab, and tezepelumab, multiple studies that are either ongoing or going to be started that really try to explore the importance of these drugs, not only in mucus plugging, but in mucociliary clearance and how the airway responds to the environment. So on that note, we had that patient that started off the case, the 42-year-old who had worsening asthma and mucus plugging. We've gone through a lot of the theoretic data and a lot of the wonderful evidence that Dr. Castro presented to us, along with some new data about how is airways hyperresponsiveness and mucus plugging modulated by some of these drugs. So I'm going to ask Dr. Castro, the patient, or the question, how would you treat this patient, or how would you consider what options you might have?
Well, as a pulmonologist, I want to see the whole CAT scan. But assuming that the patient had a high mucus plug score, I think the data you showed along with that patient's elevated T2 biomarkers would suggest that tezepelumab would work just fine in that patient. I think with the blood EOs in the 400s, an anti-IL-5 would be fine in that patient as well. And you showed some data with Benra in terms of mucus plugging. I think that would be reasonable as well. I think the jury's still out with dupilumab, but we certainly can't say that that would not work. It should work in terms of blocking the IL-4 receptor, but some additional data, we're still waiting for that Vestige study to come out. So we'll see, but I think at least those three biologics I think are all reasonable to consider in that patient.
I completely agree. I think in these severe asthmatics, where, as Dr. Castro pointed out, a quarter of these patients, maybe up to a third, have bronchiectasis, and they don't necessarily have allergic bronchopulmonary aspergillosis.
Yep.
And I think identifying them, I think up front and getting an idea to rule out bronchiectasis, but also to define, are they in the plugging phenotype? And we do have some wonderful tools to treat this. Would you like to give the summary?
Well, you want to do the Q&A or?
Or do we have questions?
Yeah, we have some Q&A questions here.
Do you want to take the first one?
I'll take the second one if you want.
Okay. Okay.
I'll leave the biologic one for you.
How soon can you see the effect of tezepelumab on mucus plug resolution? That's an interesting question. And we don't have the answer because we really only have CTs before and maybe after several weeks. The fact that we probably can see it within 3 months, I think, is encouraging. But it does take a while to unwind those plugs, and maybe things like using an acapella. I don't know. What do you think about using chest physiotherapy in this plugging phenotype? Do you think it makes a difference?
If they have significant bronchiectasis, I do with those patients. But I think it alone doesn't seem to do it. Take care of those patients.
Yeah, they're impacted pretty tightly.
Yeah.
So I think it's a great question. I don't know if we're going to get that answer, how fast it does work. I think we would need some kind of a surrogate for CT scanning. I don't know, maybe if impulse oscillometry might provide a little information, non-invasively.
Yeah. But the Cascade study at least was 28 weeks. Prestige will have a 12-week, kind of 3-month CT early on. So we'll see if that gives us some data about how quick it works.
Okay.
I'll take the next question. In patients with severe asthma and no obstruction on spirometry, would you recommend assessing for mucus plugs? So I think this gets to the point that there is an association with mucus plugging and the presence of obstruction. Certainly in the patients that we saw in the SART program, there were patients with high mucus plug phenotype that had no significant degree of airflow obstruction. So I can't use that as a parameter to decide, whether or not to do a CT. I still want to do a CT and see if they have significant mucus plugging.
Next question. Some patients, I think we just answered that. No. Actually, I'm going to give the next one to you because this really relates to the study about mucus plugging and no eosinophilia. I'll read the question and I'll get your answer.
Okay.
Some patients in Duncan's study had large amounts of mucus plugging and no eosinophilia. How does this affect the choice of additional therapy?
Sure. There was, some spread of the data there. So that is correct. There were some of these patients that did not have significant blood or sputum eosinophilia. Majority did. Certainly the mean level was significantly higher in those patients. I would, I like that we're able at least to measure sputum eosinophils because it's, I think, a more accurate reflection of what's occurring in the lungs. In those patients with low eosinophil levels, I might think about using an anti-4 receptor blocker or tezepelumab more so in those patients, right? Because we don't necessarily need the high blood eosinophil level to drive our decision making. So I think those two biologics would be my choice. I don't know.
Did you guys look at neutrophils in sputum at all in those patients and see whether that was predictive of
Neutrophils were not predictive of mucus plugging in that
Okay.
study. Yeah.
Interesting. Okay, let's do the next one. If someone had a non-contrast CT with no plugging found, is performing a high-resolution CT still recommended? And I'm kind of wondering why that first scan was done. Was it to look for tumor or embolism, or why was that done? I mean, it's a lot of radiation. I myself would probably say no, but you're not going to really answer the question with a non-high-resolution scan, I don't believe.
Well, a lot of our patients walk in through the emergency room door and automatically get a CT and
Right.
without any really input of getting high-res cuts. I would say with most modern scanners that we utilize in the ED and other settings, you get a pretty good resolution, and you can always have them reconstruct that CT.
That's
so
right.
You can have them generate high-res cuts for you if you want. So I think you probably don't need to repeat it. You just need to kind of get some more information from that CT that was done already.
What effect do these biologic agents have on MUC5AC and MUC5B? Do you want to take a stab at that?
Well, that's a great question. No one has really answered that yet. We have a study that we were talking about earlier, Jonathan, that we used dupilumab in vitro to alter what was happening to airway epithelial cells. And at least in vitro, we didn't see much change in terms of MUC5AC. We did not measure MUC5B, though. And so I suspect that there's probably going to be some differential effect in vitro in terms of MUC5AC to MUC5B levels that will be beneficial for patients, but we don't know.
Yeah. I mean, we know IL-13 has an effect. The question is, how do you block it?
Yep.
At the level of the cell. And one last question. This is an interesting one. What if a patient has mucus plugs but isn't symptomatic? So I guess you would have done that for some other reason. Maybe the patient had pneumonia and they decided the x-ray wasn't sufficient, so they went ahead and got a CT and it showed some plugging. I guess one question would be if they have asthma, but it would really depend on why you got that scan to begin with. Mm-hmm. There might be an infection, a viral infection, that's caused some transient mucus plugging or some changes in the airway. But if you happen to, who asked the question? And I'm just curious, not to put you on the spot, but if you would like to sort of flesh it out for us, but why the scan is ordered to begin with, I think has a powerful impact. But let me pose the question to you, Mario. So the person gets a scan. It was for the abdomen, but they got 20% of the lung, and you see some plugging in those critical areas in the peripheral, and you see some plugging, and they have asthma.
They have asthma.
And they have asthma. What would you do?
Well, then I would be curious. I would definitely measure their serum IgE. I would want to see, do they have evidence of sensitization to one of the molds? And then I would want to screen them to make sure they don't have other infectious etiologies for mucus plugs. So especially NTM, I would like to look for in those patients, because sometimes I've seen that and just kind of be indolent in some patients, where they have these mucus plugs, and kind of distal to that, they'll have some bronchiectasis or bronchiolectasis present. So those are the things I would go looking for if they were asymptomatic, because they both have actionable items that I would act upon, even in an asymptomatic individual. But otherwise, if they were asymptomatic and those things were negative, I wouldn't necessarily go fishing.
I might do a full PFT with lung volumes. If they've got, let's say, either a spirometric defect that the patient is a sort of a low perceiver, they might have more asthma than you think. Or sometimes people have normal spirograms and actually have a high TGV or high RV and TLC, indicative that there is significant trapping, and it might be by virtue of these plugs. So I think you probably at least want to characterize their pulmonary physiology better, get an eosinophil count along with the IgE level. But interesting situation. Well, in summary, we've covered a lot of ground. It's been a pleasure to have you all as attendees and to work with Dr. Castro, who's really very, very well versed in this area. If there's any other questions, we're going to be coming off the podium. But thank you again for attending, and we hope you enjoyed it. Have a good night.